Hi, this is Mrs. Howe. This PowerPoint podcast is on dysrhythmias. This is some background information that I will not cover in class, only because there's little time to go over this. This is usually a lecture that takes me almost 2 classes to complete, and I'm supposed to complete it in less than 1. Needless to say, it's probably going to take more than 1 class, but I'm going to try to do what I can to condense this. So, what are dysrhythmias? They're disorders of the electrical impulses within the heart that cause disturbances of heart rate, heart rhythm, or both. They may produce symptoms related to the hemodynamic effect they cause, such as a decrease in cardiac output, or they may be benign. Some dysrhythmias increase the risk of clot formation within the chambers of the heart. Your book commonly refers to dysrhythmias as arrhythmias. These terms can be used interchangeably. However, technically, arrhythmia means lack of rhythm, whereas dysrhythmia means that there's a dysfunctional rhythm. We're going to review some A&P. It's both an electrical system and a mechanical system, a pump. They must work effectively together, separately and together. The electrical system will stimulate the muscle contraction and relaxation and coordinates the forward flow of blood from the atria to the ventricles and out to the body. Every beat represents multiple ion shifts, action potentials across cell membranes that initiate an electrical stimulus and cause muscle contraction. I'm not going to review action potentials, potassium shifts, none of that, because I have not found that any of that is in an NCLEX style question on the NCLEX, and basically I feel it's advanced level for those of you who will deal with dysrhythmias in whatever field you go into on a higher level basis. Basic electrophysiology, resting potential state where cells are polarized and ready to accept a pulse. There's depolarization. This is when the cells receive and respond to an electrical stimulus, the movement of charged particles to make the inside of the cell positive. Repolarization is a resting period, movement of charged particles to make the cell negative again. I bring this part up because I want to talk about the absolute refractory period and the relative refractory period. When we get into ventricular dysrhythmias, this will become important. Your absolute refractory period, the heart cannot accept another impulse. In the relative refractory period, a greater than normal impulse can cause an electrical discharge. A good analogy to this is flushing the toilet. That time right after you flush the toilet, you can jiggle the handle and nothing happens. That's your absolute refractory period. The heart will not accept an impulse. So you can have impulses firing and it will not react to that. However, before the toilet bowl or toilet tank or whatever is done filling, you can hit that handle a little bit harder than normal and get it to flush. This is your relative refractory period, meaning that a greater than normal impulse will cause an electrical discharge before it's totally done resting. And properties of cardiac cells, you have automaticity, excitability, conductivity, and contractility. Automaticity is the ability to initiate a response. Excitability is the ability to respond to an impulse. Conductivity is the ability to transmit the impulse. And contractility is the ability to respond to the electrical impulse with a pump action. A picture of your normal conduction system. Your SA node moves down to your AV node, down into the bundles of His. The bundle of His, which separates into the right bundle branch, the left bundle branch, which both will separate out into Purkinje fibers. The SA node is the heart's primary pacemaker. It spontaneously generates impulse rate at 60 to 100 beats per minute. So if your heart rate is less than 60, it is probably not being initiated by the SA node. That's not an absolute statement. I'm just saying it's probably. It could be, but it may not be. Impulses move from the SA node through the atrial muscle, which causes atrial depolarization. This is reflected as the P wave on the EKG or ECG. Those terms are interchangeable. After this, an atrial muscle contraction should follow. Blood should be pushed out of the atria down into the ventricles. Your AV node, your atrioventricular node, these are transitional cells, and they cause impulses to slow down or delay before proceeding to the ventricles. This is important to remember when we talk about heart blocks. This is represented by the PR segment on the EKG. This delay will allow the atria to contract and the ventricles to fill. Lack of this delay time results in improper filling and thus a decreased cardiac output. The bundle of His connects with the portion of the AV node and continues through the intraventricular septum, where it divides off into the right and left bundle branch. The right goes to the right ventricle, the left goes to the left ventricle. The Purkinje fibers are the ends of the right and left bundle branches, and they are responsible for rapid conduction of electrical impulses throughout the ventricles. This leads to ventricular depolarization and subsequent contraction. Basic cardiac rhythm, things that you need to know before we can actually start talking about rhythms. What is an ECG or an EKG, which is electrocardiogram? It's a graphic representation of cardiac electrical activity. Each phase of the cardiac cycle is reflected by specific waveforms. In the lower right-hand corner, you see a QRS complex. It starts with your P wave, your Q, your R, your S, and ends with your T. The electrodes record waveforms that appear on the paper or monitor and represent the electrical current. A lead provides one view of the heart's electrical activity. Multiple leads or views can be obtained. Positioning of the electrodes is crucial in obtaining an accurate ECG. Your normal electrical conduction. Wave represents atrial depolarization. Your PR interval represents the time it takes the impulse to go from the SA node to the AV node. The QRS complex is ventricular depolarization. The T wave is your ventricular repolarization, and within that T wave, you have your absolute and relative refractory period. The absolute refractory period usually is from the beginning of the T wave to the peak of the T wave, and the relative is the rest of the T wave. This is a better picture of the intervals on an actual EKG graph. We measure these intervals in blocks from left to right. Each little block is 0.04 seconds. 5 blocks is 0.2 seconds. We'll get into this a little bit later. Here you can see your different intervals and how they're measured. Monitoring. Various forms of continuous ECG monitoring. There's 3, 4, and 5 lead systems. There's also something called a 12-lead EKG. It consists of 12 leads or views of the heart's electrical activities. It uses 10 electrodes, resulting in the 12 leads or views, to provide detailed diagnostic information. 6 of these leads are limb leads because the electrodes are placed on the four limbs in the frontal plane. The other 6 leads are called chest leads because the electrodes are placed on the chest. It's a one-time picture. This is not continuous monitoring. Accurate placement of the leads in a 12-lead ECG is crucial. Interpreting 12-lead ECG is more than rhythm interpretation. This helps us determine injury, ischemia, or infarct of the heart also. Excuse me, I have to move a cat out of the way. Standard limb leads are leads 1, 2, and 3, which are down here at the bottom, 1, 2, 3. You can see the pictures are slightly different. And this is the way they're looking at the heart. Lead 1, they always go from negative to positive, is looking straight across. Lead 2 looks down diagonally from the right shoulder to the left leg. And lead 3 looks from the left shoulder to the left leg, giving you different representations of pictures. Do you have to remember this for a test? No, this is just background information to make things understandable. Augmented limb leads are your AVR, AVL, AVF. Also look different. Notice AVR is going downward, where AVF is going up. This is called a negative deflection in AVR and a positive deflection in AVF. And basically, there's nothing wrong here. They're perfectly normal waveforms. It's how the leads are looking at the heart, which direction. In limb leads, they're actually looking out away from the heart towards the shoulders and the feet. Your chest leads, most commonly, this is V1 is right of the sternal border, and V2, sorry, I keep losing my cursor, is to the left of the sternal border. V3, V4, V5, and V6 follow suit down around the left side of the chest. V4 should be in the mid-clavicular line, fifth intercostal space. V6 should be in the mid-axillary line, fifth clavicular space. With a large-breasted woman, these may be a little bit lower to go underneath the breast. You cannot lay these on top of the breast. And you can see the depiction here that there looks a little bit different depending on how it's looking, because this is looking in towards the heart. This is what a lead EKG looks like once it's taken. You have leads 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, and at the bottom here you have rhythm strips. You have a rhythm strip in V1, a rhythm strip in lead 2, and a rhythm strip in V5. When you're continuously monitoring an ECG, it's good to monitor in 2 different leads so that you can see if there's anything happening in a different part of the heart. Basically, lead 2 looks at the inferior portion of the heart, where the V leads will look at the anterior lateral portions. So it's always good to monitor your patient in a lead 2 and one of the V leads. Most commonly, you'll see V1 or V2 position. Continuous monitoring, either 3, 4, 5. Most telemetry floors in most facilities will use a 4 or 5 lead system. We do not put leads on the limbs because of the movement. That's only used in the 12 lead because it's a one-time shot. We have the patient lay very still when we take that. It's either hardwired, meaning there's a cord attached to the electrodes which attaches directly to the monitor on the wall mounted at the side of the bed, or it's telemetry, which is like this little box here on the right-hand side where the electrodes lead to this little box which can be worn in a pocket or a pouch right on the patient and makes the patient more mobile. How do you remember where your leads go? There's a few different ways to remember. The oldest one, I think, is white on right, smoke over fire, meaning the white electrode goes on the right shoulder, smoke over fire, black goes on the left shoulder, red goes over onto the left abdomen, sorry. 3 lead right on the right over the fire. 4 leads, you have your white on the right, your black on the left, your red on the lower left, and then there'll be a green, which should be on the right lower. abdomen. 5 leads are the same as 4, but we add a V lead. It's a brown lead, and it should be in a V position. Usually you'll see this in V1 or V2. All right, so measuring the parts of the ECG. I already touched on this a little bit. Each of these blocks highlighted over here, this is considered a big block, and from left to right, it's 0.20 seconds. Within this big block are these 5 tiny little blocks. One of these blocks is 0.04 seconds. This is how we measure our intervals. In your EKG packet, practice packet that I sent to the bookstore, I also loaded some of it onto D2L. I have strips with blocks just blocked out and ask you to practice counting blocks to get used to that. Before we were able to do that in class, however, there's not going to be time for that this semester. Depiction, which makes it a little easier to see. Shows that 0.20 block bigger and pulls out that 0.04 second block for you to see. What are our normal intervals? So this is something that you have to memorize. And to determine whether you have a normal rhythm or a dysrhythmia, you have to be able to measure your intervals. Your PR interval is 0.12 to 0.20 seconds. Your QRS is 0.04 to 0.10 seconds. Your QT interval is 0.36 to 0.44 seconds. Now, your QT interval varies with your heart rate. Very slow or very fast heart rate changes this, and 0.36 to 0.44 in a very slow or very fast rhythm may be abnormal for the patient. So when it's very slow or very fast, meaning less than 60, greater than 100, you should go with the fact that the QT should not exceed half the previous R to R interval. You're saying, oh my gosh, I'm so lost. What is the R to R interval? Well, on this picture, it depicts it. The R is the top of the QRS complex, and you just measure how many blocks are from one complex to another. Then you measure your QT interval, and that QT interval should not be more than half of that R to R interval. If it is, it's a prolonged QT. Why is this important? Because this affects our refractory period, absolute and relative. If our QT interval is too long, that means we have a longer relative refractory period. That means that an impulse can hit the T wave and send the patient into a lethal dysrhythmia. There's also medications that can prolong the QT, and you have to know what those medications are to give safe care to your patient so you're not putting them into danger by prolonging their QT and putting them at risk for a lethal dysrhythmia. There's many, many ways to calculate the rate. However, we are going to do a simple down and dirty method because most of those methods that they use are for regular rhythms. This is the most popular method to use for an irregular rhythm, and it works for regular rhythms. Now note, it's not an exact determination of the exact heart rate. It is an estimate, but it is a close estimate. Basically, you get a 6-second strip, and those big blocks are 0.20, so you need 30 of those big blocks to get 6 seconds. EKG paper is marked with little lines. Go back to the previous slide that I showed you with the different intervals, and you'll see those little marks at the bottom that indicate what 1 second is. And you can figure out what 6 seconds is from that. But basically, how you figure out your heart rate is you look at the number of QRS complexes and you count them in your 6-second strip. Here there's 8. 1, 2, 3, 4, 5, 6, 7, 8. We take that times 10, and our estimated heart rate is 80. Very easy method to calculate a rate. Oh. I, in the EKG practice, also put strips in there. You could practice picking out what the P wave is, the QRS is, the T wave is. Also put some sheets in there that you could practice counting interval spaces, what your PR interval is, what your QRS, what your QT is. You'll notice in the papers it says ST segment. Ignore that. Measuring ST segment is not a left to right, it's an up and down, and that is much more advanced than you need to have. All you need to know is your PR, your QRS, and your QT interval. So, how are we going to tell if we have a normal sinus rhythm or a dysrhythmia? We're going to go through a rhythm strip evaluation. In class, I will give you some sample rhythm strips to practice, and hopefully we'll be able to practice in class together a little bit. Step 1 is you need to determine your heart rate. Is it fast or slow? Get a 6-second strip and look and count. Number 2, we're going to determine if it's regular or irregular. We don't need fancy calibers to figure this out. Just take a sheet of paper, a blank sheet of paper, and mark 3 consecutive R waves on your sheet of paper. That's the top of the QRS complex. Then line up those lines up through all the complexes on the strip. If all the complexes are at those regular intervals, it's regular. If they fall in between the lines you have drawn and it looks irregular, it is irregular. So we need to know how fast it is and if it's regular or irregular. You're already halfway there with knowing what kind of rhythm you have. Next, we need to look for wave. We need to know if they're there or not. And do they occur regularly? I always ask, is there a P wave for every QRS? Do they all look similar? And then we're going to measure our PR interval. It's the beginning of the P wave, end of the PR segment. Refer to the previous slide where those intervals are marked out for you. Once we know that we have a P wave and we're measuring our PR interval, we want to know, is it normal? Is it between the 0.12 to 0.20 normal interval? Then we move on to the QRS. It's the beginning of the QRS complex to the beginning of the ST segment. Now, not everybody has a visible Q wave. Q waves are very tiny sometimes, unless the patient has had a myocardial infarct. And then they will be very pronounced. So I say it's the beginning of the complex because you cannot always determine a definite Q wave. Is it in the normal range? Then, after you determine that, you're going to measure your T interval. It's the beginning of the Q wave or the complex to the end of the T wave. Then you're going to say, is this rhythm normal or abnormal? If everything that you've gone through in these steps has come out normal, you have a normal sinus rhythm. If not, you have some type of dysrhythmia. This is just a little algorithm that can kind of help you out without measuring intervals, just knowing whether it's fast or slow. Well, you would have to measure your QRS. Fast or slow, regular or irregular, whether or not you had a narrow or wide QRS, what the rhythm could possibly be. This is just a quick down and dirty thing. This is not a scientific guide by any means. So, normal sinus rhythm. That means we have normal electrical and conduction activity in the heart. We have a normal wave, a normal PR interval, normal QRS segment, and a normal T wave. Not all normal sinus rhythms look exactly the same. Depending on what lead you're looking at or the person itself and what kind of history they have, they may be altered. However, if it meets the criteria in that 6-step process, it's a normal sinus rhythm. Regular rhythm, your R to R interval is constant. It's 60 to 100 per minute. Less than 60 or greater than 100, it's not a normal sinus rhythm. wave for every QRS segment. Every P wave looks alike. The interval is 0.12 to 0.0 seconds. QRS is 0.04 to 0.10 seconds. And this is what it looks like. And you can tell they look somewhat different because they're all looking at different leads or views, whatever direction the energy is traveling through the heart. You can see in that bottom strip you have two different leads. One has a positive deflection, one has a negative. They're both normal. It's just the view that that lead is looking at the heart. If you would take time and measure out all those intervals would be normal. So I have gotten you through to know what a normal sinus rhythm is. You're asking, what are we going to have to know for the test? What are we going to have to know for the NCLEX? Basically, what you need to know is what a normal sinus rhythm is, what your normal intervals are. You need to know what dysrhythmias do to you, what symptoms they produce, what treatment you need, and nursing interventions you need to follow to take care of your patient with a dysrhythmia. The most popular dysrhythmias tested on are AFib and ventricular dysrhythmias, which will be coming up shortly. If you have any questions, please write them down, bring them to class. Remember, most of this material will not be covered again. Refer to your EKG practice packet to practice measuring blocks, picking out your P wave, your QRS, your T wave, and measuring those intervals, the PR, the QRS, the QT. Thank you.